A 4-year-old girl from Manila, Philippines, arrived at the outpatient department with a 2-year history of abdominal pain, without any accompanying fever or chills, no gross hematuria, no spontaneous passage of stones, and only microscopic hematuria. A computed tomography scan revealed a Staghorn calculus on the left side, measuring 7.3 by 4.4 by 3.4 centimeters with a Hounsfield unit of 1034. Additionally, there was ureterolithiasis on the right measuring 1.4 by 1.3 by 1.1 centimeters with a Hounsfield unit of 840. And cystolithiasis, which measured 1.8 by 1.2 by 0.9 centimeters with 841 Hounsfield unit. The patient was scheduled for operation and underwent cystoscopy and bilateral retrograde pyelogram, during which no ureterolithiasis was noted on the right side, hence a DJ stent was inserted on the right. However, ureterolithiasis was noted on the left and a guide wire could not be inserted, hence a percutaneous nephrostomy tube was placed. The patient then underwent cystolithotomy. A subsequent CT scan revealed ureterolithiasis on the left, measuring 6.6 by 1.4 by 1.2 centimeters, likely due to dislodged stones from the left kidney. A DJ stent on the right and a nephrostomy tube on the left were seen. The patient underwent a second operation. The procedure included a cystoscopy, the removal of the DJ stent on the right, and a ureteroscopy on the left. Once again, a guide wire could not be inserted, hence it was placed in the prone position. A nephrostogram was conducted to choose an ideal puncture site. A percutaneous renal access on the superior pole was done and guide wire inserted and serially dilated up to French 14. An 8.5 French mini nephroscope was used and nephroscopy revealed stones, prompting the use of a holmium laser for laser lithotripsy. During the fragmentation of stones with the holmium laser, visible bubbles occurred. These bubbles appeared as cloudy white hydrophobic formations in the saline and emitted a distinct rotten egg odor. An in vitro study showed that free cysteine, sulfur, thiophene, and hydrogen sulfide gas emerged when cysteine stones were broken up with low-power and high-power holmium lasers. These hydrogen sulfide-containing gas bubbles may complicate the surgery and pose a potential risk of toxicity to the patient as well as to the personnel in the operating room. The accumulation of hydrogen sulfide-containing hydrophobic gas bubbles during cysteine stone fragmentation may lead to 2 clinical problems. First, hydrophobic clustered bubbles may reduce image quality during PCNL, thereby prolonging operative time and decreasing the stone-free rate. Second, hydrogen sulfide gas carries a risk of inhalation toxicity for patients and healthcare professionals in the operating room. Following 60 minutes of lithotripsy, a guide wire was passed, and a double J stent was inserted along with a nephrostomy tube. The patient was then scheduled for a second-stage supermini PCNL. After 2 weeks, the patient underwent a second stage of supermini PCNL, utilizing a pneumatic lithotripter. Ultrasonic and pneumatic lithotripters will not cause chemical decomposition, hence these could be used in cysteine stone surgery. We successfully cleared the stones up to the distal third after 90 minutes of lithotripsy. We placed a DJ stent and a nephrostomy tube. The patient's hospital stay was unremarkable, and she was eventually discharged. 2 months after the second stage supermini PCNL, a repeat CT stonogram was requested, which showed distal ureterolithiasis measuring 2.4 by 1.1 by 1 centimeter with a Hounsfield unit of 777. The patient was subsequently scheduled for a 4th operation. During this operation, the patient underwent DJ stent removal on the left, followed by ureteroscopy and intracorporeal lithotripsy with pneumatic lithotripter. We pushed back the stone fragments to the kidney. The patient was then repositioned to a prone position for supermini PCNL, where extraction of the stones was performed using a suction sheath and stone basket. Antegrade flexible ureteroscopy and final nephroscopy was done to check for residual stone fragments. A 4.7 by 16 cm DJ stent and nephrostomy tube were inserted. The patient's hospital stay was unremarkable, and she was eventually discharged. Patient was prescribed potassium citrate and hydrochlorothiazide by her pediatric nephrologist and advised to increase oral fluid intake. 5 weeks postoperatively, a non-contrast computed tomography was requested, confirming that the patient was stone-free. The patient then underwent cystoscopy, DJ stent removal. This case outlines the complex treatment of urinary stones in a 4-year-old with cystinuria. Stones from the left kidney was dislodged and migrated to the ureter, complicating access and removal. The initial holmium laser lithotripsy was further challenged by hydrogen sulfide gas production, which reduced visibility and hindered effective stone fragmentation. The patient required multiple surgeries including cystoscopy, ureteroscopy, and staged PCNL, each guided by imaging to monitor stone location and treatment success. Despite these challenges, the comprehensive, multi-step approach ultimately achieved complete stone clearance for the patient.